Hi, I'm Dr. Cana. I'm professor in ophthalmology and I'm specialized in oculoplastic surgery, cornea and ocular surface diseases. Now, today I would like to give some brief answers that we get from our patients. Those are frequently asked questions and they are about the procedures that we do in our clinic. To start with, the first question is, what is evisceration, eye removal? Do you take out all the contents of the eye? Well, evisceration is a surgical procedure performed to remove non-functional ocular tissues. We keep the white shell, which we call sclera, and the muscles attached to it. And to obtain the volume, the old volume, we put a spherical implant inside this shell in order to get best cosmetic results afterwards. This surgery is done under general anesthesia, and the implant that we place inside the scleral shell can be either silicone or acrylic or porous implants. This implant will be chosen by our oculoplastic surgeon to get the best result in each patient. And after the surgery, we place, at the end of the surgery, we place an implant like conformer. It's kind of a shell which prevents shrinkage of the fornices, and fornices are very important for us to place prostheses after the healing. There is another surgery which is called enucleation. In that surgery, we take out the sclera as well, but put and attach the muscles on the implant that we have placed during the surgery, and the healing process is very similar. After the surgery, your eye movements will be less than the other eye, but it will be non-detectable, and most of the patients are happy with these prostheses. The other question is, when is evisceration advised? Well, this surgery is done in blind patients with no prospect of recovery. So in a blind patient, a patient who has lost their perception of light, and especially if they have pain, this is generally due to end stage of glaucoma, we advise to do evisceration. Also, in injured eyes after trauma, if you have scars and if the eye is getting smaller and the color change, we also advise to do evisceration surgery. Sometimes infections, endophthalmitis and also eye tumors are some of the indications of this surgery. In my experience, actually, another important aspect is psychosocial aspect. When you look someone and if the eye changes, it can be the size of the eye, it can be the color of the eye, it really makes a definite drop in quality of life. So it can affect family life, it can affect social life, or even it can decrease the work performance. So when we do this surgery and place prostheses on top of it, people have nearly normal social life, and it affects the quality of life. So this is another important indication for advising this surgery. Coming to the third question, is surgery the only way to improve cosmetic appearance? If the eye is not so small, sometimes we put prosthetic contact lenses. These are special colored contact lenses, and it blocks the whitish color of cornea. So when you look from opposite side, you may not understand that that eye is not seeing at all. So this is an option, especially if your eye is convenient for contact lens use, but one must be aware of that. These lenses has to be used in proper rules, with the proper rules, and like a normal contact lens, you have to obey all the contact lens using application rules. In my experience, I sometimes give prostheses before surgery. This has two advantages. One of them, some of the patients wouldn't like to go on with the surgery. They want to try prosthetic lenses. These are colored shells. They are very big and they have a size and picture on top of it like the other eye. But unfortunately, as we place it on the cornea, and the cornea is a very sensitive tissue with lots of nerves on it, when you place this shell on the eye, people may feel uncomfortable. If this is the case, they will be sure that surgery is the only option. On the other way, if they are happy with the prosthesis, we can delay the surgery and they can try the prosthesis. The other advantage for me, I know that my patient, before going for an irreversible surgery, has tried all the options that can be done, putting a check in every opportunity. And after that, they will be also aware of what will be gained after the surgery. So this is a very important aspect in my experience in my clinic. The other question is, what happens after the surgery? Well, there will be a pressure pack on the eye after the surgery when the patient comes out of the surgery. This pack is actually for preventing more hemorrhage, preventing swelling and bruising, and we want our patients to stay at the hospital for a couple of days, sometimes for 1 day, sometimes it will be 3 days. And during this period, patients can experience some pain, but they will be reduced by painkillers. After 4 to 6 weeks, we just check the healing, and if the healing is okay, we prepare the patient for prosthesis. We take the pictures of the other eye and make a custom-made, prepare a custom-made prosthesis and apply this on the eye. So our patients will go on with more similar and best cosmetic results to their normal routine life. After this, patients should clean their prosthesis periodically, but this depends on the needs of the patients. Some patients need to do it very frequently, and the others may need it very rarely. But the nice part of this prosthesis, they don't have to take it out during sleep, while they go to sleep, and while they are even swimming or doing sports and doing any other social activities. So it's nearly going back to the normal social life, normal routine life. Yes, this question is another, going to another subject. Why do you have a droopy eyelid? My one eyelid is lower than the other, and can it be fixed? Well, This condition is called eyelid ptosis. There are two muscles that elevate the eyelid. One of them is levator muscle, which is the strongest muscle, and the other one is inside the eyelid, which elevates the eyelid as well, but it has a smaller strength, let's say. And if the strength of these muscles decreases, you will have a droopy eyelid. You can have, or someone can have, ptosis due to congenital reasons. This means when the baby is born, there's ptosis. And sometimes we get ptosis later on in our lives, and they can be caused by trauma. Even little traumas like placing contact lenses in a wrong way is one of these little traumas, can cause droopy eyelids, ptosis. Sometimes allergic patients having long-term swellings after any disease, or having after trauma, sometimes we have long-lasting swellings. These may also cause a dehiscence of the levator muscle, which weakens the function. Mechanical lesions, like you may have a little heavy mass on your eye. This can also cause a mechanical ptosis, and we in this case remove this mechanical tumor or mass out of the eye, and this will release the eyelid droop. Apart from that, if we see an acute ptosis, we always consider the neurological disease. So one must be aware of neurological aspect of ptosis and must go to the oculoplastic surgeon or ophthalmic surgeon to be able to evaluate the condition. But in my clinic, I can say that most ptosis patients are age-related, loosening or weakening of the muscle, levator muscle. So, and it can be fixed due to the reason actually. If it is mechanical, we take off the mass. If it is neurological, we go on with the neurological causes. If it is congenital, we go on with the surgical procedures. So the next question is, when is the best time for ptosis surgery? Well, we get this question very frequently, especially if the patient is a child. Well, surgery timing is very critical in these children. As there's if the eyelid droops and closes the pupilla, the child won't get a proper image, and this is in this case, development of amblyopia is inevitable. So if you're seeing a patient with droopy eyelid and the droopiness closes the pupilla, then we don't wait and we do the surgery as soon as possible. In children especially, we prefer doing these surgeries in general, under general anesthesia. But if the eyelid do not close the pupilla, then the vision is good. We work with the pediatric ophthalmologists in these cases very closely. If it is not obscuring the pupilla, so we prefer to wait until the child comes to age 3 or 4 years. And in that, if in that age, if the ptosis is mild to moderate, sometimes we prefer also to wait until the age 18. We love doing this surgery under local anesthesia, because while doing this surgery, if it is under local, we put the patient in sitting position. In this way, we can just evaluate the level of the eyelids, if they are symmetrical, if the opening is enough or too much. So as we prefer doing it on the local, we also prefer, if the situation is okay, if the clinical status of the toes is okay, we wait for years of 18. In adults, it's not critical, timing is not critical unless the patient is uncomfortable with the cosmetic appearance. But again, if they have some problems, we do it whenever they want. There's one important point that everybody has to realize. If the patient in older ages, and if the droopiness is moderate, even moderate, it can just affect the visual side. And especially if it is in one eye, it can affect the balance of the patient. And this imbalance may cause frequent falls. And we all know that falling down is can be a very important issue in elderly patients. So while timing the surgery, we always take this under consideration. And the other question is, what types of ptosis surgeries are there? Do you cut the eyelid, or are there any other possibilities? According to the severity of ptosis and degree of the muscle function, we can decide to do different kinds of procedures. Before the surgery, we do phenylephrine test. If the phenylephrine test is positive, and if the ptosis is mild to moderate, we can do surgery from inside of the eye. We use the muscle, smaller muscle, which is called Müller muscle, and this surgery is called conjunctiva mullerectomy muscle. It's a very short operation, and healing is very quick. And patients don't have any incision on top of the eye. So patients with good results of phenylephrine test and patients who don't like an incision on top of the eyelid, we generally prefer to do conjunctiva mullerectomy, which is done inside of the eyelid. But if phenylephrine test is negative, or ptosis is moderate to severe, and the muscle function is not as good as we would desire, we do levator muscle surgeries. In this surgery, we put a cut on the eyelid, on the lid crease, and after the surgery, we just put stitches which will be removed in a week. The scar will be traced. And during this surgery, levator surgery, as I mentioned before, we do it under local anesthesia, and we put the patient on sitting position in order to arrange the symmetry. But as we are dealing with a dynamic tissue, as we are dealing with muscles, not a static tissue like skin, after the surgery, we may have over or under corrections. So one patient may have to go on several second or third time for surgical interventions. So we always explain this to our patients, and patients has to realize it before starting this surgery. There's another case that we have a very little levator function with severe ptosis. In these cases, we use frontalis suspension surgeries. For suspension, we use some silicone rods or fascia lata, and we suspend the eyelid to the frontalis muscle above the eyebrow. In this way, after the surgery, patients using the eyebrow and frontalis muscle, they can elevate their eyelids. But unfortunately, as this is a suspension surgery, the eyelid level is nearly fixed to a level. So when they look down, the eye may keep a little bit open, and when they go to sleep, the eye may stay open. We call this lagophthalmos, insufficient eyelid closure. And if this is the case, we have to protect the cornea with using artificial eye drops and gels. This is very important. And if this causes any damage to the cornea, we have to droop the eyelid a little bit more. So let's go on with the other question then. Yes, this is also a frequent question. What is pseudoptosis? Now, patients really frequently come to us with, well, I have droopy eyelids. But to say ptosis, we do have a muscle dysfunction. But in pseudoptosis, we have excess skin on the eyelid, or we have excess fat, or you can the patient may have a droopiness of the brow. So this is not real ptosis, but it's due to these effects. In these cases, patient may experience closure or narrowing of the visual field. And as the lid sits on the eyelashes, eyelash position may change as well. We do see frequent blepharitis, we do see increased dry eyes in these patients. And the other thing that we frequently see is, as the patient tries to elevate the eyelids to get rid of this excess skin, they may experience headaches, frontal headaches in the afternoon. In these cases, we just do blepharoplasty surgeries. This is actually known as cosmetic surgery. And we do this in pseudoptosis patients, and we just excise the excess skin off. Sometimes we need to take off little fat as well. And if there's other conditions like brow ptosis, we all do the surgeries focusing on the pathologies all at once. This surgery is I enjoy doing this. So if I see pseudoptosis, and if that condition affects my patient's social life, psychosocial life, or even they may have reading difficulties during the night because of the droopiness, I prefer doing blepharoplasty to these patients. After blepharoplasty, which is done under local anesthesia, patients will have stitches on the eye, but these stitches will be on the lid crystalline. So after the surgery, after several weeks, patients will have only trace scar unless they have other pathologies. These stitches will be removed in a week, and swelling may last 2 weeks and sometimes more than this. But if the swelling lasts more than 2 weeks, generally there are some systemic conditions of the patient, like thyroid disease or allergies, or taking some other medications. Coming to the, I think, last question that we are going to mention today is the complications of blepharoplasty surgery. Incomplete closure is one of the most important conditions after the surgeries. And in order to prevent, we give great care to prevent this during the surgery. We try not to remove too much skin away. And as we are ophthalmologists, we are very keen on ocular health and eyelid physiology. So we try to protect the eyelid physiology. It is a very important point to prevent this. Again, too much fat excision may cause hollowing and deep sulcus after the surgery. Personally, I prefer doing more natural looking surgery results, and in this way I can prevent these kind of complications. Of course, getting scars, infections, or under corrections are possibilities which are seen very rarely. So for these reasons, this operation should be carried out by experienced oculoplastic surgeons or surgeons who are especially trained in this field.